Welcome to Season 3 of Talk ADHD, Conversations Worth Having. This podcast is here to help you make sense of ADHD. Using a combination of interviews with the leading voices in the field of ADHD, as well as commentary from Andrew and I on the topics that are being discussed around ADHD, we hope this podcast and its evidence-based approach is what you need to really make sense of ADHD for you. Andrew is an ADHD clinician and a neurodevelopmental expert, and I am a neurodivergent author, educator, mentor, and consultant. It's our passion to make sure that everything we do and everyone we speak to talks from an evidence-based approach. So sit back, relax, and enjoy this episode of Talk ADHD. Hi, it's Matt. I've literally just finished editing this week's episode of Talk ADHD, and I wanted to be very upfront with you. This episode was recorded in an empty conference room in a Congress Centre in Prague. I did the very best I could to make the recording as good as possible, but the sound is far from perfect, and I am no sound editor. So I have now genuinely spent approaching 5 weeks trying to learn sound editing to get the sound for this week's episode as good as possible so that you could all hear what Steve Faraone had to say. I've also done my very best to match up the subtitles that you'll see to ensure that you can read along. I hope that you really do enjoy this. And thanks for bearing with me.
Hello again, we are back with Talk ADHD, and this is a really important and exciting episode for Andrew and I. We're currently sat in a conference room in the beautiful city of Prague, attending the 10th Annual Congress of the World Federation for ADHD, and we are incredibly honoured and fortunate to be joined by Steve Faraone. So, Steve, the first thing I want to ask you to do is, would you just give us a brief introduction to who you are, what you do, and then we'll dig into some information.
So I'm a clinical mostly research these days. I used to see patients, but I gave that up about 15 years ago, so I could devote my life to research, which is now my passion. Mostly focused on ADHD, other areas as well. I'm a professor in the Department of Psychiatry at Student Upstate Medical University in New York. I'm also president of the World Federation of ADHD. So I'm in charge, if you will, of this meeting here that we're having. It's really great that you all came here to interview me, and I hope other people to provide such good information about ADHD.
For a lot of our audience who may not have heard of the World Federation, what is the World Federation? What's it? What are our, I suppose, its core aims as president? What does that mean you are trying to achieve? And I suppose, how have you found this week, and has the Congress been as successful as you would have hoped?
Well, I'll start with the last one. The Congress has been amazingly successful. We have over 2,000 people have registered and are here at the Congress to learn about ADHD, and that's just wonderful because that's the mission. The mission of the World Federation, put simply, is to educate the world about ADHD using the best evidence that's available. And I emphasize the word evidence. It's not about my opinion, your opinion, some opinions. It's about what do the data show? What does the science of ADHD tell us about how we can best help people with disorder, how we can help clinicians help people with ADHD. Of course, we also value clinical experience in some cases where there's no data. Having top clinicians help other clinicians understand how to use medications, how to employ psychological therapy is extremely helpful. And that's the kind of information that we're exchanging.
And actually, you said it was important when we met that Matt, you need to come to the next Congress. So why was that? What was it about when we met and we started this podcast that you went, we need to be here, you need to experience this?
I think it's about the evidence. That's the key word. It's not about opinions. There's a lot of opinions out there, isn't there? And sifting through that and helping people make sense of what is fact, what's opinion. This sample of one type of stuff that we see on social media. And so I knew it was important for you to see the other end of that spectrum, cold hard evidence. This is the research. Because I think a lot of what we're trying to do with our podcast is bridge that gap, isn't it? Because there's inevitably a gap. It's a different perspective. That's what I wanted you to see, and I think you have.
I can completely confirm that. I have. My eyes have been very wide, and it's been fascinating. And then some of the seminars and the lectures that I've been able to attend, and the conversations I've had. What I would say is this: I've heard social media mentioned in almost every session I've been to, at least once. And it's interesting for me that the conversation has been about how do we ensure that the information that gets widely shared on social media matches the evidence base and the knowledge base and the understanding. With your career working with psychologists in ADHD, what's your take on that at the moment? Do you think that's a challenge for professionals?
It's a huge challenge. I'm trying to do my best. I have a website called ADHDevidence.org where I provide blogs, I provide some videos, and so forth to help educate people about ADHD. But quite honestly, I'm a nerdy professor. I'm not going to take. There are ADHD influencers out there in the web that, are getting millions and millions of people to look at them because they post stupid little videos, allegedly describe ADHD, talk about their personal experiences. And they're very attractive to me to watch. And it's sad because what it really does is it stigmatizes the disorder. It puts misinformation into the minds of people. And sometimes that means that somebody who has ADHD doesn't realize they have ADHD because they didn't get information. Sometimes it means somebody who doesn't have ADHD thinks they have ADHD because someone is providing a description that actually is not ADHD. And that confuses people. It actually overwhelms healthcare systems because people come and say, I have ADHD, I'm sure I did. I saw Mr. TikTok and he said this and that, and that's actually wrong.
Yeah.
We do try as a profession of clinicians and scientists to use social media to some extent, but as I said, it's difficult for us because we're kind of nerds that love to do science. We love to focus on what we do, like to help them, but we're not necessarily that great at communicating to the public about this.
That's a really interesting comment. You use the word we just learned quite a lot now, and I wonder very often whether you see at some point a coming together more of those social media personalities who begin to realize, wait a minute, if we work together with the researchers and the scientists, rather than opposing them, I wonder if that starts to bridge a gap. I wonder if that starts to mean that the information is still shared in different formats. So you've got ADHD evidence, ORG, but then we have the future, Instagram, and TikTok. But the information starts to maybe marry up a bit more. Do you see that ever happening?
Well, I do. This is an example of it beginning to happen, right? Trying to get the top influencers involved is very difficult. We've approached some of them to come to meetings, approached some to talk to them about my ADHD evidence website, and you get a response typically like, "Oh, we'd love to do that. It will cost you $20,000 for us to, talk to you about your website." I mean, these influencers who come across as just the person next door who's, providing funny information, they're making loads of money doing this. It's basically a business for them, and the science doesn't fit into the business model for them. That's really the problem.
So as you guys were talking there, I was thinking these 5 signs that you've got ADHD and how frustrating those reels are, because it's not possible to say in 5 signs you've got ADHD. Yeah, people want that snappy, yeah, that's it, they want that answer. And the gap to bridge is, and it's a word I've used on the podcast before, it's more complicated than that. How do we translate these really complicated ideas into something that can be a soundbite? Because at the moment, the people who are doing it are doing it badly. And as Steve says, it's harmful. It's not just harmful to people who have ADHD, it's also harmful to people who don't. And the wider stigma that goes on because it muddies the waters. It's not an easy thing to do. No. And it's so easy to translate sort of sound bites into, these are the 5 signs that you're a woman with ADHD. Well, no, that's not helpful. That's harming people. But there's got to be a way, and I know that's what you and I try to do with the podcast.
Yeah, I wanted to add to that, first of all, 100% agree with what you said there, Andrew. The idea that you can fit the diagnosis of ADHD as a simple, soundbite. It's quite ridiculous. We unfortunately live in this era of alternative facts, and sadly, my country has contributed to that. But nowadays, there's so much information out there, and the media doesn't help us at all. For example, you might have a debate on a television show between, it could be me, and they could bring in somebody who knows actually nothing about ADHD, but they're just kind of a popularizer of ADHD. And if we were to have a debate, the audience would say, oh, this is a balanced view. We have two sides. Well, actually, it's not a balanced view, right? Sometimes there are people with expertise, and there are people without expertise. And some people listening to this saying, oh my gosh, this guy's full of himself. He thinks he's an expert, but he thinks just because somebody who had lived experience is not an expert, and I should see him more. And I'm saying, well, wait. I'm saying you should listen to me more about the scientific facts about ADHD. You should listen to a person with lived experience about what it's like to have ADHD. And that might be very helpful, but you shouldn't confuse the two. And this you're somebody who's had a person with ADHD. You can convey certain things to the public about that. But it doesn't mean that you can explain to them genetics of ADHD. And some people confuse that. They might say, oh, well, this fellow's got so much personal experience, if he says anything about ADHD, it must be true. This is not the case.
Yeah, you have just used a word that has come up several times in conversations in Congress, which is expert.
Yes.
Now, it's a word I will never attribute to myself. No matter whether I've been invested in this for 16 years, no matter how much research I do, no matter how much I've learned through Andrew and through professionals like yourself, expertise is not something I feel that I can attribute to myself. It's interesting hearing you say that. And your description, I think, has really landed with me. It's being able to help people understand that there is a difference between someone's experience and the information they've gained, and I think the value of that. Now, you're right. We've had conversations about lived experience this week. The value of lived experience cannot be understated. What ADHD means to Andrew or me or anyone else diagnosed with the condition, is unique, but will never be the same. It's important we empower people to explain that to others, but that doesn't mean that lived experience speaks for everyone. My issue is that people seem to think, because of that misinformation that we see, that the evidence also doesn't speak for everyone, and that the research doesn't speak for everyone. And I know we've been challenged on this before. And I wonder why you think that might be the case, that's an attitude we see as well.
Well, it's a little bit of that stigma in mental illness. Okay, now I'm using the term mental illness, and some people say, oh my gosh, I don't have an illness, I don't have a disorder. Well, we're health professionals. We treat disorders, we treat problems. And I know some people aren't happy with that idea. They think, no, I'm just a little bit different from other people. I'll give you an example of how I think it's important. So recently, a colleague of mine prepared a big proposal to do a clinical study of ADHD treatment. Be part of the planning for that study, we put together a panel of people with experience. In this case, we studied children, so we got parents of kids with ADHD. We told them what we were doing, what did they think about it. We told them what we were measuring that we thought might be important outcome. They told us what we thought were important. And we ended up kind of converging with them on a protocol that we hope will eventually get funded in the study. And this is it's a growing movement in the U.S. and around the world, in Europe for sure, to incorporate those lived experiences into the way we do research. So people should understand there's no way that we undervalue the experience. I just want people to understand that I can't, for example, substitute my scientific understanding of adult ADHD into what it means to live with adult ADHD. Those are two different things. And I wouldn't claim to be able to do that. And someone who is an influencer on social media, is an adult with ADHD, shouldn't claim that they know everything about ADHD. Just because they're an adult with ADHD, they can't claim that they know the best treatments. They can't claim that they know about the genetics or about what environmental influences are. They can talk very deeply about their own experience. That's great, but the universe of people watching needs to be able to separate the two pretty clearly, especially to making important decisions. This is my concern, right? When it comes down to somebody making an important decision about their life, let's say they hear a social influencer and they say, I changed my diet and now I'm eating this and that and I feel fine. And someone's, I'm going to stop taking my medication and I'm going to go on this diet and I'm going to give it a try for a year. Well, that's good, right? Because when that person goes off the medication for a year, if they have ADHD, they might get into a car accident because not paying attention when they're driving. There are serious implications not following the correct advice. So that's my concern.
I 100% hear that. Andrew, I'm going to pass this one to you. You are a clinician with ADHD. And I know, because we've discussed this, there is a difference in the way people view how ADHD may impact you because you're a clinician, because you're a prescriber, versus how it may impact someone who isn't a clinical professional. And the attitude very often is, that's easy for you. You know everything. Piggybacking on what Steve has just said there, why do you think that people perceive ADHD is easier for you, and therefore your opinion almost doesn't count?
I think the issue is in those four letters. ADHD does not define it. I have some difficulties with attention, some hyperactive symptoms as well, but I am not ADHD. And some people define themselves that way. Steve put a slide up yesterday morning of sort of the coexisting conditions. It really hammered home something that's been going a lot around in my head. People want to reduce their struggles down to those four letters. And each of us living with ADHD is so much more than those four letters. You know, that range of 18 symptoms. We all have our own story. Everyone's ADHD is like a fingerprint because it's only part of who we are. And I think it's very seductive to say, I am ADHD, and that defines everything. So I find in clinic, people come and say, the medication's not working. And actually, when you talk it through, medication is working, it's just not doing what they expected it to do, which was sort their entire life out. And there isn't a pill to sort your life out. There's a pill that can help you concentrate, be less impulsive, that can then enable you to be more effective at sorting things out. And that has been my experience of making sense of my ADHD. My experience in clinic is taking people from this position of ADHD does not define you, through to medication is a tool that can help you, amongst other things, have a more enjoyable, productive life. Yeah. But there always seems to be attention from, that's attention, not attention, from newly diagnosed folk. That diagnosis and the really, really effective medications that we prescribe is just going to be revolutionary because they hear on social media medication is life-changing. Now I found it was for me. But that was a journey. That wasn't an overnight success because I took a pill and all of a sudden I could concentrate. Yes, that first dose. Yeah, whoa, I really do have ADHD because I doubted it until I took medication. But that was the start of the journey. And when I look back, I think, yeah, that was life-changing. And it felt it at the time. And people's journey through titration is often, whoa, this is different. And then it becomes a bit more normal. And we talk about multimodal approaches where people need more than, wow, there's a switch on the back of your head that says now you can concentrate. Because often people will get that sort of experience from their first dose of medication. But that is the start of a journey. And I don't think we're good at communicating that. And we're not good at communicating the individuality of how ADHD sits in. You know, for example, in my life as a husband, a father, you know, all of that is Andrew. It's not ADHD, and there's just a tinge across all of that other bits, all of those other bits of Andrew that define the shadows that cast slightly differently because of ADHD.
I'm going to come back to something, and I think I want to bring in what you said about this concept of neurodiversity, the neurodiversity movement at this point. And you just mentioned your slide that's talking about coexisting conditions. Now, neurodiversity is a word, often gets confused in my experience, and people think it means different things. Where do you feel for ADHD sits in this conversation? Because I've met people at the Congress who think it sits very much within the neurodiversity conversation, and those who think it absolutely shouldn't sit within the wider neurodiversity movement. So we'll start with that, and then there's a couple of follow-up questions, I think, about coexisting conditions.
Well, I think at this point we don't have a choice. ADHD has been placed in the neurodiversity movement on the internet and in many places. So for us to say that if it's not part of that conversation, would really just be putting blinders on. I would like to help the audience understand the way I think about neurodiversity. So neurodiversity, what does it mean? Well, neurobrain diversity. People in the neurodiversity movement would like the world understand that there are people whose brains work differently than the average brain. And that's not wrong. That's actually correct. Depends on how far one takes that. So some people take that as far as saying, and therefore we don't have a disorder, we don't have an illness, we're not part of, there shouldn't be this medical model that we're put into, because then that puts us in a box and it makes us look abnormal and it makes people, it stigmatizes us. I'm not saying that that they're wrong about stigma is real and it's a problem and we need to deal with it. But when one does that, when one takes what's currently a disorder and says, no, it's actually not a disorder, then guess what happens? Well, in the United States, the insurance company always say, they don't have a disorder. Why should we get you treated? Just as one simple example. That's a very practical problem we have to be careful about. Well, you might say, okay, Professor, is there a scientific reality to neurodiversity? And actually, there's an interesting reality in the data. I always go back to data. Do we have data on the question that can address this? And we do. You saw it in my presentation today. And I presented really two pieces of relevant data. One is that if I take a measure of ADHD symptoms that's been validated many, many times, and I go out in any population, whether it's here in Prague or it's in the UK, the United States, I think it's 1,000 people, and I get ratings on this, and people will score from, say, 0 to 40 or whatever it is. What do we see? Do we see a very separate group of people with ADHD at one end and then people without ADHD at the other end? We don't. We don't see anything separate. We see this very graded distribution, called normal distribution, where some people, very few, have very low ADHD symptoms. Very few people have lots of symptoms. Most people have symptoms that are in the middle. If we say, is there a clear cut point between people with and without ADHD? There's not. I can't point to that distribution cell. These people have ADHD, these people don't. There's no clear cut point at all. Then we go to some biological data, a little more complicated. Here in the age now, what we call genome-wide studies, where I can take a blood sample from you, I can take it to the lab, I can say, your DNA tells us that your ADHD risk score is 2.4, whatever it might be. I can do it for anybody in a population. If I go out to the population, I get a Prague, Denmark, United States, I collect from thousands of people, get all the scores, and I plot them against like I plotted symptoms. I get the same distribution. I get a very graded distribution. Just remember, this DNA score is essentially your genetic risk for ADHD, and that genetic risk varies, we say, continuously in the population. There's no separate group of people with ADHD that have very high genetic risk, and then everybody else has low genetic risk. Everybody has some genetic risk, and there's no clear cut point. I can't say over here these people have ADHD on the right, and the people on the left don't have ADHD. So what does that mean? Well, it does mean that, as the neurodiversity movement suggests, the ADHD genome and then the ADHD brain it's part of the continuum of what we call a typical variation in the population. It's nothing unusual about it. They're no more unusual than the people who have low levels of symptoms, who have low genomic risk. Those people are also unusual, right? They're unusual. We don't say they have a disorder because they don't come with us saying they're having problems. Like being poorly in school, my wife's having problems maybe getting too angry. But they're unusual. They're as unusual as people who are unusual in statistical sense as people with ADHD. All of that is very consistent with the neurodiversity movement. Somebody might say, well, then why do you have to say it's a disorder? And, well, my answer to that is really simple. I say, you probably go see if you're an adult, you probably get a checkup every once a year with your doctor. Your doctor takes your blood pressure. And guess what? You have a blood pressure. Everybody has a blood pressure. If you look at the distribution of blood pressure, there's no actual cutting point where people have high and low blood pressure, but doctors decide that at a certain point, person's blood pressure is so high, it needs to be treated, and it's a disorder. We call it hypertension. Now, we don't have a hemodiversity movement in the world, right, where people say, well, there's blood pressure diversity, we shouldn't have a disorder called hypertension. Why don't we have that? And we have this neurodiversity movement that says we shouldn't have a disorder called ADHD. I think it's part of the stigma of ADHD that we do that. And we're separating it. We're saying, no, this is different. We're saying somehow ADHD and other psychological, psychiatric conditions are somehow different from medical conditions. And that's something many of us in the research world have been fighting for many years, because fighting based on that, because we think it's stigmatized disorders, as they're different, you're separate. And it actually, we think, causes problems with, for example, public funding or insurance funding. Like in the United States, some insurance companies treat what we call mental disorders differently from other disorders. And that's just not right. People who have these problems deserve the same amount of help as people who don't have these problems. I'm going to go on a little bit because it's a related concept in this neurodiversity movement. It's not the same, but it's related to say that so we're not only are we diverse, but our ADHD also gives us special skills and that you're ignoring. I think somebody wrote a book once called Gifted ADHD, ADHD Superpowers. Well, again, I'm sorry, audience, you're not going to be happy maybe when I say this. But, well, first of all, I should say that I think the research world hasn't done a good job trying to document skills associated with ADHD. There's very good researcher who's starting to do this. I see presentations there. And there was some, she has been finding some positive skills in ADHD, but we really don't understand them very well. What I can say is there's no clear...
Hi, it's Matt. Sorry to butt in the middle of the episode. I just wanted to have a chat to you about the sponsors for Talk ADHD, which we don't have. In fact, we're never going to be sponsored. So that means that this is a passion project for Andrew and I, and we really rely on your support. So if you can take time to like, comment and subscribe, it really helps this podcast grow organically. And that means it reaches more people, and more people get to hear the information that you know is helping you. So once again, thank you for listening or watching wherever you do, but please do like, comment, subscribe, and turn on the notification bell so you never miss any information about our latest episode. But for now, let's get back to this week's episode.
Evidence that ADHD provides people with these kind of superpower that you hear sometimes. Now, sometimes I do these Ask Me Anything sessions on these social media platforms, right? And I've noticed one of the things that it's called the ADHD community, that the moderators there do not allow people to be talking about superpowers. They call it toxic positivity. And I love that term because it's exactly what it is. Because what happens, this is a case again of people not understanding the difference between, it's what Andrew said, right? That ADHD, because a person is diagnosed with ADHD, that doesn't define their entire person. Andrew has ADHD. It may help him in certain ways because he has insights and empathy that other people don't have. And so sometimes people in social media who have ADHD and who are, say, incredibly creative too, they say, I love my ADHD, but it's made me so creative. Well, why is that toxic? It's toxic because there are lots of people with ADHD who are out there saying, how come I can't find my superpower? What's wrong with me? I have double problems. I have ADHD and I'm so, I just can't, I don't have a superpower. How come I can't find that? And it just confuses people. So this is my concern about these movements, is that they intend to help people, but they can indirectly harm people.
Oh, I completely agree. And again, I know our audience that know us know this is our views on it. A lot of people will find that really hard to hear. But you're right, and I am one of those people before diagnosis who had struggled my entire life. I mean, my entire life. I often tell the story when I do public speaking. Between 17 and 36, I had 35 full-time salaried jobs. I was from 30 of them and quit the other 5. I can't find a superpower in that, apart from being super good at being sex. And that didn't feel positive to me. Since understanding myself, separating the 4 letters from me, I now understand the things that I've always actually been good at. My ADHD symptoms may in some ways assist me, but they don't make me good at those things. They're part of it. Right? The follow-on question is this, and we've had discussions about this only this morning at the conference. We talk about coexisting conditions. Very recently, there is an awful lot of conversation about this new condition, almost of AUDHD, autism and ADHD. And are they separate? They're part of the same continuum? Is it a new diagnosis? Andrew and I have been talking about this at length, so I'll come to you first. We've spoken about this. we both know the two conditions intimately for ourselves and people around them. But this new conversation, I think, is part of what Steve was just saying about people trying to find definition that justifies the things they've experienced and, in a way, does other them. And it's the conversation, don't other me, don't tell me I've got a disorder, but I'm AUDHD, you're not. And I wonder why we think that maybe.
So this ADHD concept speaks a lot to me about people's understanding of what that last D means, what disorder means. So Steve talked about that normal distribution curve and where do doctors draw the line? But actually, while Steve was saying that, it's quite clear to me that it's not doctors drawing the line any more than the hypertension. You know, there are people out there living with hypertension that don't know they're hypertensive. You know, I lived 45 years with ADHD, not knowing that I had ADHD. I started diagnosing people with ADHD and say, you seem to get this. And you know about ADHD? I said, no, my school reports are fine. Yeah. And it was only when I took a step back, because I had to, because things were going wrong, that I was able to say, hang on a minute, maybe that's why I'm having this difficulty. Coming to AUDHD, this is about the lens through which we see things. So ADHD has a very clear set of symptom criteria, as does ASD. And they're very separate. There are lenses through which to see difficulties that people experience. So to add those two together confuses the process that has been collaboratively delivered through an evolutionary process, because the science of medicine is a collaborative process with the population, I think. You know, someone comes to a doctor and says, these things are wrong, what can we do? Either the doctor knows because they've seen it before and there's an evidence base, or, oh, that's interesting, let's investigate that. So it's for me, the concept of ADHD is about people looking for an identity, for a label that says, this is me. But that's not what we're doing when we give a label of ADHD. A label of ADHD, in my mind, is about, and I've said this on the podcast before, is about opening up the evidence base that says, if you meet those criteria, this works. Yeah? So to then conflate two of those into this new thing to gain an identity, I think is unhelpful. But I can understand why people want to do that, because they're looking for that one explanation of how I am, who I am, and I am like that person, not that person. And I think there's work to do in social understanding of what these diagnoses mean and how that is separate from an individual identity. Does that make sense?
That's a very beautiful description of a problem we face. And you know, all individuals are searching for their identity. What am I? Why am I in this world? How am I different? What's my tribe? Who do I belong to? Yeah. And so somebody can take a new label and say, oh, this is me. I belong to this group of people. And I do get that. It provides a group you can talk to. You can get sympathy from them and so forth. People like us that are involved in mental health treatment or in research, we use these labels. And sometimes people criticize that. Why do you have to label us? We use them for important purposes because they tell us what to do. And it's right that saying someone with ADHD is important, not because it identifies them as this is the essence of your soul. No, not at all. It's important because it tells the person what to do. It tells them what medicine to use, what psychological therapies might work. It has implications. It tells them what might happen to you in the future if you don't get treated. And that's why we use these labels. Now, this AUDHD, it's a phenomenon that occurs a lot with people that have these kinds of psychological issues. We don't, if somebody has diabetes and ADHD, I don't think there's a diabetes ADHD kind of group that's all of a sudden creates a new category. No, it's just you have diabetes, the doctor will treat that one way. You have ADHD, the doctor will treat that one way. Is it common for people to have spectrum disorder and ADHD together? And the answer is yes. The process of discovery is very long. It takes a while. Let's go, back to 1980 when the DSM-3 is our diagnostic manual that's used to make these diagnoses. Back then, the belief was that these conditions that we call disorders were very separate. If someone came in, you want to decide, did they have ADHD? Did they have autism? Did they have anxiety? And you usually just try to find one problem. And back, a good example, back in 1983, you were not allowed to diagnose both ADHD and autism in the same person. You were not allowed to diagnose depression and panic disorder in the same person. There were very explicit rules. No, that's wrong. You're making a big clinical error. Now, fast forward back to here we are in 2025, the diagnostic manual has not changed. Now, you're allowed to diagnose ADHD and autism together and panic disorder and depression. The viewers and people think, oh, these doctors, they don't know what they're doing, they keep changing their mind. No, this is how science progresses. Okay? Science is a cumulative process. You learn, you do research. Even back in the 90s, I was doing a lot of research with colleagues. It was actually pretty common for people to have more than one condition. And that led to change in how we do the diagnostic process because it makes a difference. It tells the doctors, tells the healthcare people how they can best help these people. And that's
Which makes me wonder now, in you saying all of that, and that's how science progresses and that's how understanding progresses, the conversation that's really dominating the press, I think in the UK and I think in the States as well, in other areas, is these conditions are now being overdiagnosed. Too many people are getting the diagnosis of autism or ADHD, or too many people think they've got ADHD or autism, and the waiting lists are now so long that they can't get a diagnosis. So I wonder what your views, both of you, are on that. Is that part of the process of understanding and the science evolving, and more people meet the criteria, and you've spoken about those normal standards in the middle, or is it something else? Is there another reason for that, do you think?
This is a very complex question. Okay, so I'm going to be a little bit maybe professorial, which will put some of your people to sleep, but you can edit it out.
Go for it.
So we do know, for example, there was a study done in the United States where they looked at a diagnosis of ADHD in all of 50 states of the United States. And what these researchers found was that there was a fair amount of regional variation, that there were low diagnostic rates in some states, ones that seemed fairly high in other states, that maybe 12%, 15%. And so they raised a concern that this is a problem. And some of the work that they presented were fairly convincing that it has something to do with the degree in which different states provided special services to children with ADHD. And so that the ADHD diagnosis is useful because if you have a diagnosis, then you can get a special service, let's say in school systems. And so there are kind of if you will, pressures on healthcare people to diagnose for reasons other than the actual patient's condition. There was a presentation, the same thing. It showed how there was variation in the diagnosis in Norway. Now, I've looked at these studies, and I always ask these researchers the same thing, which is that have you ever gone back to actually, these are big epidemiologic studies, right? They're looking at overall rates of diagnosis. That in many cases, they don't actually look at the children being diagnosed. And I say it would be great if you went back and found out, was any harm being done here to these kids with these diagnoses? And usually the answer, we don't know. The answer is this is a big epidemiologic study. We can't actually look at the individual child. And that's fine. I understand limits of balancing. It takes us back to my description of the normal distribution of semi-distinct population. Because, people think that when this question of overdiagnosis is presented to the public, it's presented implicitly as a person either has ADHD or they don't. And if you confuse the two, you're making some huge error. Now, if I say to you, what would you think if misdiagnosis meant that somebody who had, well, for example, in the DSM, you have to have six symptoms of hyperactivity or 6 symptoms of attention to be diagnosed with ADHD? Well, I said, what would you think if person came in and had 5 symptoms of activity, 5 symptoms of attention, had 10 symptoms of disorder, and that they were massively impaired, either at work or at school. And the doctor said, I'm going to treat this person even though they don't meet the diagnostic criteria. Is that an overdiagnosis we should worry about? And you might get people saying you should worry about, oh, no, you can't do that. But of course, people aren't saying that about people whose blood pressure isn't quite over the threshold. But the doctor says, your blood pressure is kind of high, and you're obese, you have these other risk factors. I really think you should put you on a medication. You don't see people complaining about overdiagnosis of hypertension and so forth. In fact, I believe at least in the U.S., the hypertension criteria were, changed a while back. They made the criteria more liberal, let more people be diagnosed. We didn't get lots of media people say, oh my gosh, what are you doing? This is cabal from the pharmaceutical companies trying to sell more. And it's, again, part of this big ADHD and these conditions that they just generate this kind of media frenzy for criticism. So people need to understand that Yes, there are regional variations that can be a concern, but there's not some kind of wholesale overdiagnosis that's harming people in a way. If anything, what's most harmful to people is denying treatment, because if someone doesn't have ADHD and they're diagnosed with ADHD, I haven't seen anyone, this is the thing, okay, I have never seen anyone, again, I'm a research-based person, right? And when you look at people saying, if you diagnose someone with ADHD, they don't have it, you are hurting them. And I will say to them, have you ever documented that any kind of harm has occurred? I have never found anybody who can say that they documented it or someone else has done it. That's my concern. The bigger harm comes when you misdiagnose or underdiagnose.
I'll come to you because that word misdiagnosis is one we've used hundreds of times on the podcast. It doesn't mean what people think it means. I think, listening to that, misdiagnosis isn't a deliberate sort of Machiavellian attempt to harm someone. Actually, it's about a judgment of a person, right?
So yeah, it's this line again that we're drawing. And you know, earlier you were talking about, is it this or is it that?
Yeah.
And going back to Steve's normal distribution curve, it's not binary, we are a diverse species. I think that concepts like misdiagnosis, but they underrate the value of what healthcare is about in terms of ADHD. And I think we're seduced into the hacks that we've talked about in the podcast, where you just want an easy way. Is it this or is it that? It's more complicated. But as a species, but also as scientists, we want to draw lines. It helps us make sense of things. So I think it's possible to have more than one reason, more than one understanding, more than one perspective, and not be intimidated by another perspective, but actually that there's a conversation to be had, and it isn't a simple binary decision. If Steve's patient with 10 symptoms that doesn't meet the diagnostic criteria, he's absolutely right. We should be treating that person because they potentially got more difficulty than someone with 6 symptoms, more than likely have. But because they're not crossing a line in a book somewhere, we've taken that. And I think probably in clinical practice we do blur those lines, and perhaps that's confusing to people. Yeah, we talk in absolutes in science. Yeah, science says this. It's more complicated, but we're looking for these simplifications. So often when I see tensions, that tension is indicative of complexity.
So, I'm very conscious of your time. There's lots going on. I think what I'm taking from listening to you both and trying to process this is there's no easy answers to this, but there are tools and there are lots of evidence bases that say if we follow protocols, if we use the things we have learned and we use the knowledge that's evolved, the aim remains to be to help. There is no point in this conversation where I felt that science and research is trying to cause harm or restrict care or restrict treatment or underdiagnose. It's about trying to make sure that the right people receive the right care in the right way at the right time. The question I'll ask you to round up is, if you could give a summary message in your position, in your experience, to people living with ADHD, what would it be that you think would help them understand that?
Well, I guess one thing I would say to people is that you use and believe in science in your everyday life. Like they go, now we have made incredible progress. And I'm personally so pleased with all the progress that we've made. So I would tell people to look towards the evidence when you're trying to evaluate what someone's saying. Try to figure out, are they actually talking about real evidence that is going to help you make a very important decision in your life? I have known too many cases where people didn't follow evidence. And well, I can give you a simple example. A friend of mine called me up once and said, hey, my grandson, I'm pretty sure has ADHD. But my daughter thinks so too. But, the last 5 years she's been taking to nutritionists, to homeopaths, to all these alternative treatments. She just has heard that these, the medical treatments for ADHD are dangerous. And I'm really concerned about him because now he's in 2nd grade, not doing well. Would you mind talking to her? I said, no, of course, I'd be happy to talk to her. So talk to her. And I said, look, I understand. Those are precious. We're always concerned to hear this stuff. internet about ADHD medications. Why don't you do this? Why don't you remember, first of all, that it doesn't have to take it forever. You take it for one day and decide, I don't like this, it'll be fine. Then do that and just take it one day at a time. I suggest you do it for at least a week or two and see how it goes. And she still think about that. Honestly, I thought she would do nothing, but she actually did that. And I got a call from her 2 weeks later. She said, oh my God, I wish I had talked to you 5 years ago. It's a different boy. And she had been dealing with all this misinformation. And what had happened is, what people don't get about these alternative treatments is that they think, oh, well, it's much better to try this diet because there's no adverse effects to this diet. Medicines have, adverse effects. And what I say is, that's not treating as adverse effects, right? The child's, say, 5 years old, and you don't treat them, you don't give them the correct treatment for 5 years, you've let them spend half their lives not developing social skills, not developing life skills, getting alienated from their peers. That is a real adverse event, much worse than any of the adverse effects that the medications cause. Another thing I really want your audience to understand is something I usually say, but it's very related to what Andrew has said about ADHD, not being your essence, not being your soul, that you should think of that as a small part of you that you have to deal with. It can have a big effect on your life, but it's a small part of you. We all in our lives have other parts of us that are strong points. And I always encourage people to find your strong points. I mean, you found your strong points since you're an amazing interviewer. You're very good at this technical equipment with the podcast. That would probably confuse me. And find your strong point. You might be a great cook. You might be a great musician. Find those things. Don't say it's because of my ADHD that I'm a great cook. Just enjoy being a great cook because you're you. You're a complex person and as a multivariate personality. But do deal with your ADHD bothering you because that's what's important. If you think you have ADHD, it's not bothering you, that's something different. But deal with it.
Yeah. Andrew, I'll go back to you. That last statement goes back to something you said on episode 1. That you and Sarah have both said, which is rarely have you ever had anyone come seeking a diagnosis when everything's going well. When life is, right? It's when the wheels have fallen off. Yes. Yes. And that really speaks to that logic. And I really appreciate everything you said there. And it's quite interesting for me. You say, I'm going to interview and I'm going to do this test. Just for clarity, I'm not medicated today. Deliberately, because I need my brain going that quick to be able to cope with having all of this. But I think that's the reality of it. You talked about choice. I know how I work better now than I ever did, so I could remain sort of that choice to go, like, no, the medication's here, not that. But I really appreciate that. I think this conversation has, for me, made sense of what science is, made sense of what research is trying to achieve, and made sense of what people like you are trying to do with it, which is help. That's it. You are trying to help. You are trying to learn and continue to learn to help more people. Please take those words that you've heard from Steve and from Andrew. Please remember that lived experience, your lived experience is incredibly important and it's valid and you should have the tools to explain it. But the science and the research is what's enabled you to understand your ADHD in the way that you do. And we shouldn't be fighting against those sides of science and research and lived experience. We should be celebrating that they exist in this conversation. I really hope that this has been an episode that's useful to you, Steve. As I say, I'm very grateful for your time. I'm grateful for your candor and your honesty, and to you as well, Andrew. And we will be back very soon with another episode of Talk ADHD.
Thanks again for watching and listening to this week's episode of Talk ADHD. We really do hope it helped. And as you now know, it really helps us if you can like, comment, and subscribe to this channel and this podcast. Your help helps this channel continue to grow and helps our information reach more people. And we'll see you again very soon for another episode of Talk ADHD.